Thank you very much. Howard Hyatt just leaned over to me and said, "Are you presenting on messenger RNA?" No, Howard, I'm not. No, come back. He'll never let us, he gets embarrassed when we say, "Hey, you discovered it already. We didn't need to work on it." Betsy, just as you were speaking, I was thinking about this family, and that doesn't ever sound hokey if you've trained and worked here. It's exactly the term. I was in Haiti the week before last, and on service in Mirbalais, and which Betsy came and cut the ribbon on. Seems like a long time ago. It was just a few months ago. It's right after the Boston Marathon bombings, and we're just thinking, there's a reason that nobody who reached a hospital after the bombings died, and that's because we have hospitals. We have big hospitals, beautiful hospitals with we could call them redundant systems with backup after backup after backup, team after team, best nurses, best units. And, to be in Haiti 2 weeks ago, doing consults and feeling like I could be at the Brigham South is a very gratifying feeling. And it's not really about our own feelings, although I saw a lot of people from the Brigham there. I was seeing patients with Natasha Archer, Koji Nakashima, a number of physicians and nurses who are from the Brigham. But the most exciting thing was that we were also working with 14 new residents, 5 in surgery, 5 in pediatrics, and 4 in internal medicine. Of course, Haitians, who have just begun as the first young Haitian physicians ever to be trained in rural Haiti. And I think this is one of the answers to what we always hear about the brain drain. You say all these talented professionals don't stay in a place like Malawi or Rwanda or Haiti. It's not because of the salaries only. It's because they don't have opportunities to provide good clinical care and to learn and to generate new knowledge. So the notion of a teaching hospital, a place where you deliver care, but also learn as you're doing it, work in teams, and train, is a very, very powerful notion. And it can't be done without the research component. So when Barbara Beer, to whom I'm in great debt, asked me to come here, I said, well, I know there are better researchers. A lot of you probably wouldn't even know my field, which is not the field I'm going to talk about. Hint, it's not messenger RNA or molecular biology. I'm going to talk about the kind of work that we can do when there's substantial support for a platform of global health equity, which requires multiple methodologies and, again, real teams. And that's what I'll just give a few examples, all of them involving Brigham faculty and trainees, and of course all of them involving real partnership with people who are from and work in their countries of Peru, Rwanda, Haiti, Lesotho, etc. Now, I said here, it seems when Paula Johnson was giving the Zhao lecture, and I got to introduce her, I said, this is probably the epicenter among American teaching hospitals of global health equity. And the E word's important, right? Because we can't say, okay, we're going to do a research project in the middle of Rwanda that's going to receive funding from the NIH, no problem. You have to build the platform, just as it took 100 years to do here at the Brigham. It took 100 years to build this. As one of the first hospitals ever built to be teaching hospitals. Of course, we're going to argue with folks in Baltimore about it, but you think about it, the proximity to the medical school is really something post-Flexner report. And we're used to it now. We're socialized for success in service delivery, which we don't always get right, in research, which we don't always get right, and in training. But we've got to, I say we've got to, you have It is a project worthy of great support to build that kind of platform in a setting as unlikely as, say, a squatter settlement in rural Haiti, or a squatter settlement in rural Rwanda, or a slum in Lima, Peru. But it takes more time, it takes a different kind of approach, it takes supporters like Barbara, and people here in the leadership of this, my department, medicine, and the leadership of the hospital. Because it's not the same as doing a survey in Framingham. You're exposed to people with great need, unattended need, and again, the imperative to think about training others to be service providers, researchers, and teachers. So I'll just give some ideas, some examples. And thank you, Vicki, for not having a stroke as I was editing my slides on the way here in front of the Thorndike Research Building. Whoever's on the medical school admissions committee, please note, Vicki Koski-Carell is calm under pressure. And later, the residency program. And so our work starts, and some of you have seen this. Actually, I just sent this to these pictures to Jeff Drazen and New England Journal. And I have a piece just about what we can learn from chronic infectious disease management for the American healthcare system. So this is again, back to just think research training service before I lay it out. This is, and I don't know if Joe Radigan here, but Howard Hyatt, and I don't know if Susan Rolinsky's here, but this small group of people who started, Jim Kim among them, started a division here, probably the first division of global health equity in an American teaching hospital. And this is some of the things we've done together. By the way, it was, of course, when you start something, there are 0 faculty members, but there are probably 40. Is that a look that is admiring, or wait, you didn't get that through me?
No, I think that's probably right.
Yeah, I think we have 40 faculty members now in the division. And again, the first residency program, Global Health Equity, in the country, which is now in its 11th year. And so Natasha Archer and Koji Nakashima and some of the other doctors I see or you see, they've gone through this training program. This is a patient, his name is John, who we saw shortly after trying to build this platform in Rwanda. Peter Droback, who's on service right now, doing ID consults. When you bump into him, tell him we were talking about him. He was there, Michael Rich, Joya Mukherjee. Again, the medical staff of the division went there along with Howard and many others, and we took over an abandoned hospital. I've shown those pictures here before, what it was like when we got there in 2005. We were sent there by the Ministry of Health, and it was a place with maybe 250,000 people, 60% of them recently displaced, with no functioning hospital, an abandoned hospital, and again, no platform for delivery. That means no doctors, but also no trained nurses, no real formulary, no laboratory, no electricity. And not too far from electrical pylons, I might add. So imagine a research agenda. How would you roll that out? Say you imagined, as we did, that there would be young Rwandans who would be interested in basic science, epidemiology, clinical trials. I certainly think that's true. But how would you get there? And how would you get there if you didn't try to build a service delivery platform? And I think the answer is you'll fail. And that's why a lot of global health programs fail, is they try to skip the part about service delivery. And then, a decade later, people will say, well, why are they so resentful, they being whomever the people without access to care might be, that we're here to do research? That's what we're trained to do. And the answer is you can't skip that part of it. So you have to build the delivery platform. If there's already one there, you don't have to, right? But if there isn't one there, then that's one place to start. And so we did, and we met people. And again, the we here is not just the people from the division I mentioned, but our Haitian colleagues who had already done this kind of integrative work, building service delivery from a hospital to clinics to community health workers. So they were there too. And we saw lots of patients in serious trouble. Now, when John came in, everybody said, well, he's got AIDS. Well, he did have HIV infection, but he had very high CD4 count and a negative chest X-ray. And I'm sure you can imagine that he, like so many other people, had the chief consumptive opportunistic infection that kills people with HIV disease across that continent and in many other places in the world, and that's tuberculosis. But what did we not have? We don't have diagnostics, because the ones we were counseled to use, all of us are 19th century diagnostics. So we got a 20th century or 21st century problem, HIV-associated tuberculosis, but we're, smear microscopy on sputum, well, he has a negative chest X-ray. And now if you've seen enough cases like this, and we had, then you'd say, well, the smear, the fact that he doesn't have it in his lungs doesn't mean that's not what's killing him, because there's not that many things that do cause wasting consumptive illness like this with a high CD4 count. But imagine if we could take some of the guesswork out of that if we had proper diagnostics. That is, how about a blood test, a skin test? Skin tests, the ones that we often use that, no offense if anybody is here from occupational health. Is there? Please don't ask me to have another PPD. They're always positive. So, in any case, actually there was a joke when I was attending here a lot. When Paul Farmer talks, people listen. When Paul Farmer coughs, people run. Forgive me if you've heard that already, Betsy. So we don't have diagnostics. Now think about the therapeutics. Therapeutics aren't very good either, right? In both instances, and I would say for HIV, they're not bad. They're not curative. They're suppressive. But a lot of the drugs that we're using, and it's usually 3 drugs at a time, have a number of toxicities. So we've made a lot of progress in HIV therapeutics compared to TB therapeutics, but it would be great, obviously, to have curative therapy. And with tuberculosis, with the so-called first-line drugs, which this man received empirically, they're well tolerated. You're familiar with them, isoniazid, rifampin, thiamidol, pyrazidamide. But when you start getting in beyond that list, with the possible exception of the fluoroquinolones, which were only coincidentally discovered to have activity against Mycobacterium tuberculosis, we've had no new drug in 40 years until this year. 40 years. And these are the number 1 and number 2 infectious killers of young adults in the world. So see, that says to me that that's a research problem for basic science and the science of discovery. And then there's also a development problem. How do we develop these agents? Really 2 years of therapy for drug-resistant TB with side effects like this is a nightmare. All right, I'll go back to drug-resistant TB. Now, for this man who received therapy with first-line antiretrovirals and first-line anti-tuberculosis agents, he did very well. Again, and I've, you're going to forgive me, Howard and Betsy, but he goes from looking like Skeletor to looking like he needs Lipitor. But, but still, the big problem here, and this is, again, the most common duo that we see in lots of places I work, tuberculosis and HIV disease. No vaccine for either. No good diagnostics for TB. Good ones for HIV. Why? Because we invested billions of dollars in NIH-sponsored research to move forward this agenda. And as we have nothing developed for easy field tests, point of care tests for TB, and not even pulmonary TB. And it's not that we don't understand the genomics that we need. We already have the genome. It's that we don't have the development pipeline open either. So there's discovery, development, and then delivery. And to cut corners on delivery, is a serious error, ethical error, I've argued before, but it's also pragmatic, tactical, it's every kind of error. And again, that's why I have such gratitude to the Brigham, is because the Brigham has allowed us to say, well, we're not going to try and cut the delivery corner. We're going to deliver services, train others to do so locally, and build up capacity like that I just enjoyed in Mirabale, Central Haiti. So this to me is just, I'm going to focus only today on tuberculosis, but you imagine that there's a list of 17, 20 diseases that are called neglected tropical diseases. And that's diseases you'll recognize. They're parasitic, largely, and sometimes mycobacterial or viral. And they, again, same story. We lack preventives, we lack diagnostics, we lack therapeutics. And it's an enormous agenda. I'm just going to focus on tuberculosis for clarity's sake. So I guess on the delivery point, I just say this is extremely satisfying work. When you can be involved in discovery and development of tools, but also in delivery, it's very satisfying work. I didn't, test anybody to see if they know the field that I'm trained in. Pretty obscure. When I started my internship here 25 years ago, EB, Eugene Brownwald himself, was welcoming the interns. I was sitting up in the back. It was Cary Hall, I think. Is that right? I don't remember where we were. It could have been here because it was up. And thank you, Betsy. And he said, and we even have, referring to me and Jim Kim, we even have 2 medical anthropologists in this class of interns. And then he added, whatever that is. So my own field of interest is anthropology of infectious disease and epidemic disease. But as you'll see from the examples, we work in teams, very different from what anthropologists or historians or sociologists usually do, which is to go to a problem and archive and write a book about it. We do that too. But the most satisfying part of our work is this teamwork that I'll describe. Now, I already mentioned the dilemma. This is a picture taken in Lesotho. I'm just wondering how many people here have been to Lesotho? So, 1, 2? Lived there even. Lesotho is a small country, I think 1.8 million people, under a couple million people, that is essentially a labor pool for vastly wealthier South Africa, and like a lot of poor parts of Southern Africa are. And the further south you go on the continent, the higher rates of HIV are. The higher the prevalence is, the higher the incidence. So actually being trained in anthropology was really good because it helped me have what in very scholarly terms might be called a bullshit detector. When people said, well, there's higher rates of HIV further south you go because of cultural practices. And, an anthropologist might know enough to say, well, cultural practices like labor migration, like working in a mine, like leaving your family and your stable unit to go, could go work in a mine and stay in a hostel. So those are not local cultural practices. I'm glad there's some people chuckling because it's a sad story, that conflation of poverty and what some people call structural violence and cultural differences. And there's not a lot of proof, or I think there's very little, as you can tell, that the HIV epidemic in Southern Africa, including South Africa, all those countries around there, is not centrally related to labor migration. And it's a long time to figure that out, 30 years. Just to give you some ideas about the numbers, as this dithering was going on about cultural difference, and what was the cause, why were there so much AIDS in Southern Africa or in Group X or Tribe X, or as that's happening, the rates of HIV continue to rise, and of course so did the rates of tuberculosis. And in fact, it became virtually impossible to rein in epidemics of tuberculosis in Southern Africa. In South Africa, which is the economic powerhouse, because of jobs in the formal sector, mining, manufacturing, etc., there was more of a knowledge, in a way, of what was happening. There's more of a research and revelatory capacity. I'll give an example. This particular patient has not just those two pathogens, is afflicted by those two, but by drug-resistant forms of those pathogens. And again, why is that? And there's a whole literature, again, much of it very silly, on how patient non-compliance leads to acquired drug resistance. And it doesn't have to be silly because, of course, patient non-compliance can lead to acquired drug resistance. But is refusing to stay at home and take your medicines because you have to go back to the mines to feed your family, is that non-compliance? I mean, if it is, it seems like the non-compliance of the industries and labor practices and medical profession. We're not complying with our mobile patients. And so what happens next? Finally, if they're lucky enough to get TB meds, which they were, you have drug-resistant TB, and then it's spread, being an airborne pathogen for which we do not have vaccine or good diagnostics. It's spread as primary drug-resistant TB. And it's the leading killer not only of people living with HIV in Southern Africa, but also in their HIV-negative household contacts. It is a leading killer of children, HIV-negative children, and sisters and brothers and coworkers, because it's airborne, and we're either treating it with the wrong drugs, this particular form of TB, or we're treating it too tardily because we don't have diagnostics. So this complex, biosocially complex tragedy, that is a collision of three major epidemics: an epidemic of tuberculosis and increasingly drug-resistant tuberculosis, and an epidemic of HIV and increasingly drug-resistant HIV, and an epidemic of labor migration. That's, you take that and mix it up into a pot, and that is what you see in Southern Africa and in a lot of major cities where there's labor migration. Now, how are you going to, first of all, research training service, how are you going to take care of a patient like this and family members? One, service delivery. How are you going to train others to do that? What kind of training programs? And then how are you going to conduct research so that we can sort out not only how to manage, to prevent, diagnose, and manage these illnesses, but how to attack a lot of the silly and frankly pernicious ideas that come out whenever there's a void of knowledge. And especially if that involves poor people. I'll go so far as to say that. If we're talking about poor people with epidemic disease, and again, the epidemics can be non-communicable as well, right? You can use the epidemic to mean epidemic obesity or epidemic diabetes. I mean, I don't think it's as Nicholas Christakis, who's now defected to Chicago or some such. I don't know what happened to him. He was a classmate of mine from med school, a sociologist, physician. He studies how social epidemics of non-communicable disease are in fact just that, epidemics. It's very interesting work. But sticking with tuberculosis, what are we going to do? And it's just taking the Slutu example because I was just there not too long ago. I don't go there very often. I've been more in Rwanda, but these patients are so sick, and then everyone is willing to say, is it possible? Is it cost effective? Is this even untreatable? And I would also say to researchers, when you hear about untreatable tuberculosis or untreatable HIV or untreatable cancer or untreatable anything, it's probably a word that we should expunge from the vocabulary. And I'm not talking about heroic treatments that don't yield anything but pain. I'm talking about deciding up front for others that a very complex illness is in fact untreatable. Now, in the United States, of course, we do too much treatment, right, and of the wrong kind often. I just came from a lecture by David Jones at Harvard Medical School, in which, and it's commonly heard, a third of all medical care is probably not only unnecessary but could be harmful. But that's not true everywhere in the world, right? Sometimes there's no real access to the formal biomedical sector. South Africa is a very strange place, right? Because this is an epicenter of medical learning and knowledge and innovation. And we have many faculty members from South Africa here at the Brigham and at Harvard. A lot of firsts happen there. But right up in that same country is poverty of an epic proportion. Again, not too unlike the United States at times, or Brazil. These are places where there are several different countries in one place. Lesotho is again right in the middle of that with national borders around it. It's a sovereign nation, a kingdom, and with a deep history. Basically, 80% of the patients we're seeing who have tuberculosis, most of them drug-resistant TB, have HIV, and about 70% of them, again, Jacqueline, correct me if I get the numbers wrong a little bit, they've been labor migrants. So the epidemic caused by the collision of HIV, TB, and you could say therapeutic regimes, because again, drug resistance is inevitable, but labor migration was third part. That's all smashing together in the bodies of vulnerable people who are mobile until they die. And a lot of times they quote unquote come home. So that's how we meet people in Lesotho. Now, for those of you supporting Brigham faculty and trainees working on this, I just would again say thank you, because this is of the illnesses that I've seen over the years. Drug-resistant TB is one of the most difficult to tolerate, and it's difficult to tolerate the treatment. It certainly gives most aggressive forms of chemotherapy, which is what it used to be called, of course, chemotherapy, a run for money on terms of side effects. So you also need aggressive side effect management. Why? Again, because we haven't developed new drugs. We haven't had one in 40 years until this year, as I said already. I'm going to tell you what it is. Some of you know. So in terms of clinical care, the regimens for treatment of this disease, let's just say the more drugs at the higher doses, the better, because they're weak drugs and we haven't had good sidle, easy to take medicines in a long time. But they're difficult to tolerate, especially if when patients feel better, they feel compelled, as would you, to go back to work so that their families aren't hungry. So we've got to be innovative in terms of thinking about how we are mobile with them, difficult in any circumstances, right? How to reach them in their homes, how to help them with their side effects, and then above all, especially if they're living with advanced HIV disease, to not have them be reinfected with another strain of tuberculosis. When I started medical school 30 years ago, it was received wisdom that immunity to tuberculosis was conferred by natural infection. And it was, there are all kinds of errors that were perpetuated. It was also received wisdom that this was the more drug resistant the isolate, the less transmissible it was, the less lethal it was, or less pathogenic. Again, things that were, I said silly. It's not silly, that's more pernicious, because in fact, it was not true that you can't be infected multiple times, and it was not true that these are not lethal. It wasn't true that they were only lethal in people living with HIV and with advanced immune destruction. It wasn't true that they were less pathogenic. None of those things has really been borne out by serious inquiry. So who did the inquiry? And I'm proud to say that a lot of your colleagues at the Brigham did. I was involved more in the caregiving and am, but Partners in Health and its Brigham partners, if you start looking at Peru, Lesotho, Russia in Siberian prisons, Rwanda and Haiti has by now treated the largest cohort of patients with extensively drug-resistant tuberculosis anywhere. It's about 15,000 people. And that's just multi-drug resistant and up. And so when we heard about, again, untreatable TB or TDR, totally drug-resistant TB, we said, wait, let's just go back and look at our records and see how many of those patients with totally drug-resistant and therefore untreatable TB were in fact cured. And we published those data too, because we had gone off trying to build a service delivery platform that generates new knowledge and that trains new people. Let me just give some examples, and then I'll open it up. So this is a slide I made for a talk at the Brigham some time ago. And when this grant was awarded to Megan Murray, who many of you know, who's an infectious disease physician epidemiologist, and who has headed up the research program at our new division, and again has had many champions in this room. She received the largest grant from the NIH to study these matters that had ever been given. And you'd think I was going to, and it was a big grant, but it wasn't $100 million. It was a $15 million grant, and it was focused in Peru and could only be applied for, much less conducted as research, after there had been a delivery platform built, because it took 10 years to convince people locally and internationally that this was not an untreatable disease. Now, if you were a young Peruvian, I just was thinking, I just popped into my head a family that I saw. The mother, this is again a slum. I should have brought a picture. It's not like rural. I mean, Lima's a big metropolitan city, 6-7 million back 20 years ago when we went there. And part of the story you'll know is we went there not to do tuberculosis work. In fact, now I'm old enough so I don't have to be embarrassed when I tell you that when I went down there at Jim Kim's request, I said, well, the one thing I don't think we have to worry about, let's focus on women's health and primary care. The one thing I don't think we have to worry about is TB, because they have a really good national TB program. Never were more erroneous words spoken, because not only was there already a rip-roaring epidemic of drug-resistant TB underway, we didn't know it, but it took the life of our American colleague who was working there. And that's how it was revealed to us. This is not a Brigham faculty member, although received care here too late. So the idea that TB was less virulent or not transmissible was revealed, again, tardily to us, that those were not only, those were errors, those were scientific errors. The idea that you could treat drug-resistant TB with the very drugs to which the infecting strain was by culture proof resistant, also dangerous myths. But 10 years it took, and treating thousands of patients with Peruvian colleagues, before we could credibly say we're going to focus on the research questions that really should be funded by the NIH and the NIAID. And they were. And just to go to this is the Holy Grail, you could say, of research and Brigham research, if I may, and I think Barbara will agree with me, is trying to link some of the basic mechanistic questions, basic science work, to basic epidemiological work about a not at all basic problem, which is, again, a disease which was mistakenly thought to confer immunity, but in fact can infect people multiple times. And then there's acquired resistance. So you had acquired drug resistance, that is through what we don't call noncompliance, but rather failure to afford patients the opportunity to take their medications conveniently and with proper management of their side effects. So acquired drug resistance is then transmitted as airborne drug resistance, just like acquired drug resistance with HIV is transmitted as sexually transmitted drug-resistant HIV. 1945, 100% probably of all Staph aureus isolates were susceptible to relatively modest doses of penicillin. Now, they're less than 5%. That's what the bugs do. They fight back. But one of the ways that we fight back is linking service delivery to research. The basic science, this is Brant Schmoody, some of you will know, is here and at the Broad. Mercedes Becerra, who trained in this program and did a PhD at the Harvard School of Public Health. This did Carol Mitnick. I can't really see the pictures too well on this, but these are your colleagues who have built the service delivery platform and also are conducting some of the most sophisticated mechanistic and epidemiological research and biosocial research, which is by definition mixed methods, that's going on anywhere. And it's ethically sound because, again, it is linked to service delivery. And it's not necessary that we provide it still. Actually, the Ministry of Health, the public authorities in Peru, have taken up the care of patients with drug-resistant tuberculosis. So the 15,000 that I spoke of that Partners in Health had treated has been dwarfed by the number of patients treated by the public authorities of Peru, saying, you know, we do have to worry about these complexities of drug resistance. We will invest in it, and they have. And that, I'm arguing, takes a long time to build an ethical research platform that spans dizzying disparities of wealth and power and capacity even. You know, if you go to Lima, you're in a big city, you'll find researchers able to do NIH-level research. I met some 20 years ago, still friends of mine. But there's not as many as would be concentrated in this room, say. And you go to rural Rwanda, again, don't believe for a minute there are not people there who would like to be researchers. Of course, now we know that that's not true, but we knew it when we got there. Now we know it because we're working with them, having trained them. And in today's New England Journal of Medicine, and again, I have a special thanks to Barbara and to my department chair, Joe Descalzo, and to Betsy and to the leadership here. There's an article in today's New England Journal of Medicine, and maybe you won't see how tied it is to this discussion. But what about the training platforms? If we go with our colleagues, and again, remember, Mercedes was a graduate student, Carol, in a minute I'll show a couple of other people who are still residents or trainees. If we go and say, well, you know, we have our Brigham, Harvard trainees, that's who we're going to focus on. That would not go over very well in Russia, Rwanda, Peru, Lesotho, anywhere that I've been. It hardly goes over well in Roxbury, and we live there. So what about the Peruvians and the Rwandans and the Basutu and the Haitians who want to be trained? Well, in today's New England Journal of Medicine, we described what is the largest training program, medical training program, including largely physicians, specialists, but also nurses, management, in, I think, probably the history of sub-Saharan Africa. You know, South Africa aside, right, which again, as I said, is a global powerhouse. But what about in that space? Yes, there are in every big city in Africa, in Nigeria, certainly in the north, but you won't find a lot of residency programs, subspecialty fellowship programs. In fact, there were none. There's no medical school at all in Lesotho, not one. Again, they export their labor, but there's not an effort to train and retain people there. In Rwanda, one medical school. There were maybe 60, 70 graduates a year. And in the last 2 years, thanks in great part to the Brigham, there are 16 American medical schools and teaching hospitals that have faculty, not trainees, there to train Rwandans. And that is the most astounding. In my experience, 30 years of doing this is the most remarkable project in training we've got going out there. HRH is called, Human Resources for Health. And again, it's not an accident that the hospital making the biggest commitment of those 16 institutions is the Brigham and Women's Hospital. That's because our global health platform has always been linked to knowledge production, to training, and to service delivery. So again, thank you for allowing us to do our jobs properly. And I'll just, just so I just do go on when I get excited. Sorry. I'll just do one last image, it's kind of a mishmash, and I'll skip over this, but I'm proud of these people. Gustavo Velasquez, by the way, who is again another gone through the residency program and is now doing his ID fellowship, is it's a great expert already on drug-resistant tuberculosis. It's a pleasure to see patients with him. You'll recognize probably Megan Murray and Dr. Agnes Beniguajo, the Minister of Health, and Michael Rich, again, stalwarts, all of them in their own way. Dr. Beniguajo, who was the leader of the National AIDS Program in Rwanda 10 years ago, a pediatrician, there's a reason also that she is now the Minister of Health of Rwanda, is because she made common cause with partners who would respect that demand. We want local training, we want it linked to service delivery, and we want to learn how to do research ourselves. In fact, last week, Dr. Beniguajo defended, as sitting Minister of public health, in Rwanda, defended her PhD thesis and was awarded her PhD. So when you bump into her at the Brigham or in Rwanda, congratulate her. She so believes in this mission of research training and delivery that she actually completed a PhD while she was minister. I have a funny joke. I don't know if I'm allowed to tell it, but it's too late now. The day before, some of my colleagues, my Rwandan colleagues, 'cause she has a closed, old-fashioned thesis defense. And if you know Agnes, Dr. Beniguaho, the honorable minister, it's a lot more funny. But someone said, well, you must be so nervous. You have to defend your thesis tomorrow. And she said, oh, I'd be more nervous for them than for me. She is formidable. And then and this is Molly Franke, by the way. Molly Franke, who is an epidemiologist, and again, a trainee supported by the Brigham. And, it's an unusual thing to have a global health equity division where you're allowed and encouraged to bring on people like Megan brought in trainees. She was at the Harvard School of Public Health and is now at between HMS and here. Molly Franke has worked in Peru, Rwanda, you name it. The clinicians said, this idea that we could keep repeating the same research again and again, like, is it better to treat HIV disease early or late? Okay, how many times are you going to study that? Is it better to treat HIV-associated tuberculosis early or late? You can even before we had ART, before 1994, 1995, it's not like we discovered the CD4 cell and cell-mediated immunity when we discovered ART. We already knew that the lower the CD4 count, the more lethal any consumptive infection like tuberculosis would be. It's lethal in people with normal immune systems sometimes. So, a lot of us were skeptical about this insistence that you have to keep on doing randomized clinical controls trials of something that we already know is good. And I would beg of you, my colleagues, please help us fight that. It's not that we're not against randomized controlled trials, but you have to have equipoise, right? I mean, it's if you're testing something that's already been evaluated here, then it's not necessary to test it again unless there really is some new equipoise issue. So continuing to study whether or not we delay ART in patients with active tuberculosis, the time for that is really long gone, right? Anyway, the reason I brought up Molly Franke is she designed using observational methods, again, often disparaged, which is a big mistake. Forget about biosocial methods or qualitative methods, the kind I'm trained in. We ought to rehabilitate those too. And one last word on that in a second. But she used observational methods, worked with data that was already gathered, and asked a simple question. For those who started their ART early, at this time of initiation of tuberculosis therapy versus later, how did people do? And the cost of that study was under $50,000, published in a reputable journal, and showed, again, that the earlier you start ART in patients with tuberculosis and HIV, the better they do. And I guess I'm saying is that we'll never be, as a division, we're not going to ever be capable of, well, maybe someday, but depending on the setting, it's not like we're going to compete with, the TIMI trials. Going back to my training days, probably don't even remember what that is. Those large-scale trials, like estrogen replacement, for example, those are critical to the future of medicine. There's a lot you can learn, though, about having trials not in a new therapy, but a trial of equity and justice. Are we going to give proper care to a population that's lived in poverty, and what happens when we do? And that is a radically important scientific agenda that requires multiple methodologies and a lot of support. And that's what we've received from the Brigham. Last image, and then... So I was there when this picture was taken by a guy named Sergei Gitman. I'm going to give it away by saying Russian photographer, so you know it was probably in Russia. Although you might want to do a randomized clinical controlled trial of how often the word Russian was used to describe someone who was actually working in Russia. I'm just joking. Anyway, this was in 1998 in a prison in Russia, and it's a beautiful but kind of scary photograph. It's in a prison cell, and the rate of tuberculosis, drug-resistant tuberculosis in this population was startling in the extreme, and the Russians knew it. The prisoners knew it too, patient prisoners. And just to give you a number, you would expect in a good community-based service delivery program, regardless of where you were, Boston, rural Haiti, Malawi, you get the combination chemotherapy, that is the first-line drugs, into patients' bodies by making it easy for them. You should expect a cure rate of over 95% and mortality rates that are very low. Among patients, prisoners who were receiving therapy, they're on treatment, the case fatality rate was 24% that year, 1998. And again, the silly hypotheses, well, it's prison, you can't treat TB in prison. But they're a captive audience. You can treat TB. It's a great place to treat TB. And it was not that they were, hiding. And they were actually inspecting. This is not the Russians so much as they're others. They're inspecting their buccal cavity to see if they're hiding the pills. I'm like, okay, well, yeah. Sometimes people do that, I guess. But that's not why a quarter of them are dying on therapy. They're getting the wrong drugs. They have drug-resistant TB, and it's airborne, and it's spreading like wildfire in the prison. And I'll just say this. When we linked the service delivery to the training, again, how to use certain drugs that were not readily available in Russia at that time, and Sonia Shin, who I hope all of you get to meet, Sonia Shin, Jennifer Furin, Salman Khashoggi, is a small group of Brigham faculty who went and said, well, we will help roll out, first in the prison and then in the civilian sector, proper therapy, and we'll document it and we'll learn from it. Well, the case fatality, the mortality rate inside the prison went to 0 in less than 2 years. And it stayed down there in Tomsk prison. And again, the arguments that this was resistance or recalcitrant behavior or asocial behavior, on and on it goes. That's not the point I wanted to make. This year, and last year actually, medicine is once again about to undergo a sea change, just like the one we saw in 1994-95. When I was an intern here, and with Jamie McGuire and Paul Sachs later coming on board, when I was an intern, this is again skipping ahead to 93, 94, 95, there were a lot of people dying of HIV disease. When I was a medical student, in my rotations at the Mass General, at the Deaconess, at the Beth Israel, and here. Those are the 4 places I did most of my rotations. And there were a lot of people, mostly young men, dying of AIDS. By the time I was a fellow, an infectious disease fellow, triple therapy, same as with TB, 3 drug, sometimes 4 drug combinations, combination chemotherapy, came in, and lo and behold, people who were dying stopped dying. And they got up and they went home. And we still see them 20 years later in clinic. Sometimes they just come to say hi. And same thing happened in Haiti, and then in Rwanda, and then in Malawi and Lesotho and South Africa. It's going on now. What's about to happen right now in medicine is that hepatitis C is about to be curable with a multi-drug oral regimen. It's going to be 2 drugs or 3. It's going to replace pegylated interferon and ribavirin, and it's going to revolutionize the care of people with HCV disease, and the diagnostics are undergoing revolution. So we have to have an equity plan for medicine. And by medicine, I mean medicine and public health, and it can't be, when we say global, we don't mean international. We mean Boston and New York and Rwanda, Kigali, Rwanda, and Johannesburg, and Seru, and Russia. That's where this division, which has been so abundantly supported by the Brigham and by others in this room, that has been led by people like Howard Hyatt, Joe Radigan, that's what we need to be doing. We need to be thinking not about specific diseases or problems. We also need to do that. We also need vertical training programs in cardiology and surgery, and just like we're doing in Rwanda, but we also need a global equity vision that links, again, to community-based care. Because you don't need people to be in prison. Even if they're in a prison of a trial where they have to come back and forth every day to get something. We don't need that. This is chronic disease. We need partners in communities. And when we say medical home, we need to mean in the home, where it's convenient for them. That's the lesson we learned with tuberculosis. And we didn't listen. That's why we have a lot of drug-resistant tuberculosis. That's the lesson we learned with TB and with HIV, and we didn't listen quickly enough, which is why it's still the leading infectious killer of young adults in the world, although that's about to change. So this time, I hope we can get it right. We have to have a research agenda that involves basic science. That's where we got the meds. That involves clinical trial knowledge. That involves, and most importantly, and this is the point, a trial of equity and justice. Thank you very much. Thank you.